Hi, this is Wendy Bennett with the Population Health Management Masters Program, looking today at Assessment 1, reviewing Module 1. Recent decades have seen a shift from international health to global health. International health is thought more in historical terms now, having been more public health driven with principles of disease prevention, while recognizing differences in needs between different countries, partnering at local, state, national, and global levels. So, in some ways, there's still a lot of similarities, but global health, which came around the time of the 21st century, emphasizes the bigger picture, so to speak, and a more integrated approach. The book Population Health Diseases, Programs, Systems and Policies discusses the need for health sector reform, cost effectiveness, and promoting public private partnerships in health, encouraging participation from sectors other than health that can influence the social determinants of health, recognizing how these other areas impact health. And at the same time, we've also seen a growth in innovative technologies with the potential to cut down cost of care and increase access to care. So, addressing some of those social determinants also, potentially, if used well. And we have a globally aging population, which has changed how care strategically, systematically needs to be addressed. So, with an aging population, we have more chronic diseases, so the non-communicable diseases, which is different from the traditional, more vaccination program-oriented approach. We need more angles to tackle chronic disease and prevention, and we'll look at that more. There remains significant problems with the health in poorer countries of preventable diseases, and they're still the leading cause of death in under fives, and AIDS is still a very real threat in sub-Saharan Africa. I want to mention here also, because of the link with globalization that happened alongside global health, global health governance is about recognizing the collective actions needed to better protect and promote population health in a globalizing world. So that's key in everything that we're going to talk about today. One example of this would be the Global Public Health Infrastructure Network. We also have the World Health Organization, United Nations, and I wanted to mention also private foundations like the Bill and Melinda Gates Foundation that have contributed over $2 billion to global health development in recent years. Looking at how universal healthcare addresses social determinants in vulnerable population groups within these low to middle income countries. The World Health Organization states that for health equity to exist, there should be an absence of unjust, avoidable, and remediable differences, remediable differences in health across populations. In a commentary for the British Medical Journal, Stevens et al. Suggest that health equity implies that everyone should have a fair opportunity to attain their full potential health, and describes how the pandemic reinforced how far away, in truth, we are from achieving it. Many factors are known to impact health, and we know that social determinants can influence as much as 60 to 70% of health outcomes, and policy affects those social determinants. looking at policy, macro policy, has an implication on health also, in terms of food taxes, exchange rates, expenditure, education, inflation control, all impact health. But going back to social determinants within the lower to middle income countries, the main areas that have been highlighted are economic stability within the country, and within and poverty within the country, within countries, education and access to quality care. Often there's geographical limitation and rural health access. Health access, neighborhood and built environment issues, safety, roads, transportation, and social and community context. Um, so also environmental problems include climate change that can impact, especially if you have poor housing and warming conditions, hotter conditions, how that impacts health. So we'll be having global migration issues happening in the future. um, Go back here. So health and economics have a close symbiotic relationship. And Smith et al. In Global Health Diseases, Program Systems and Policies states that being poor is bad for one's health and being ill is bad for one's wealth. So it can be seen that by investing in health, universal health, we could be increasing the wealth of a country by having a more productive workforce. And a study by Fogel in 1997 looked at Great Britain over a 200-year period from 1780 to 1979, estimating 30% of per capita growth could be explained by health and nutritional improvements. At least half of the world's population still do not have access to a full range of health services. Many people who have not accessed appropriate preventive care are then burdened financially by the cost of care later down the line. As part of the global effort to improve health equity, the United Nations Millennium Development Plan focuses sustainable development goals around an idea, around achieving universal health coverage and health equity, meaning that everyone can access necessary health services of sufficient quality to be effective without experiencing financial hardship. And the World Health Assembly resolution calls for health system strengthening for universal health care, with a special emphasis on the poor, vulnerable, and marginalized segments of the population within low and middle income countries. So, and the groups, those vulnerable groups tend to be children, women, older people, people with disabilities, and living in remote areas with poor access to health. Discuss the mechanism of catastrophic health expenditure and how it affects global health. Catastrophic health expenditure occurs when out of pocket costs exceed 10% of total household spending, which in turn can lead to people foregoing necessary health care and perpetuate the cycle of poorer health outcomes due to diminished income. which in turn can negatively impact many of the social determinants of health. So we have a cycle of poverty and poor health. A study published in the Lancet Global Health 2023, and this is my additional article, by Harkenstadt et al., entitled Catastrophic Health Expenditure During the COVID-19 Pandemic in 5 Countries, a time-themed analysis, looked at catastrophic health expenditure in 2020 in Belarus, Mexico, Peru, Russia, and Vietnam. I'll just look at their findings for Mexico, as these demonstrate the problem of catastrophic health expenditure going up when protection of universal health care is taken away. Mexico increased its catastrophic health expenditure in 2020, indicating a worsening financial protection. And this was the year that Seguro Popular, the successful publicly funded insurance program for people with relatively low incomes, proven to improve access to care and reduced the catastrophic health expenditure previously, was actually replaced that year in January, by the National Institute of Health and Wellness program, a program that represents how polarized political interest can impact the well-being of citizens. It has been described as inadequate, corrupt, and driven by private interests. So this article, Hargenstadt et al., they found that in 2020, 15.4% fewer households reported any insurance coverage as compared with 2018. At the same time, catastrophic health expenditure increased among both the insured and the uninsured. And this study provides evidence of worsening financial hardship in Mexico in 2020. And this was during the COVID-19 pandemic, when the country suffered among the highest levels of excess mortality of any country, with over 200,000 deaths associated with COVID-19. So there is a lesson to be drawn from the Mexican experience, that they may do better to once again have the universal health coverage for their population. Main way of financing healthcare in low-income countries remains through out-of-pocket payments. Global health efforts are being made to tackle many inequities that have been created or worsened as a result of globalization. And the United Nations Development Programme 2030, the Agenda for Sustainable Development, has the core principle that underlies all of the goals of leaving no one behind. In the article Towards Universal Health Coverage in a Post-COVID-19 Era, Vergey et al. Discuss these Sustainable Development Goals and how every country has committed to the objective of achieving financial risk protection access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. They highlight the progress that has been made over the past 3 decades for low and middle income countries in reducing child mortality rates and communicable diseases. Life expectancy in Ethiopia is provided as an example, has increased from 47 to 66. And with this, the new problems of cardiovascular disease, chronic diseases like I mentioned earlier, cancers and injuries have become more of a problem. The study looked at to outline the key principles of a national essential benefits package, when developing universal healthcare. Um, then they used an analytical method to examine optimization of population health, reducing financial risk protection and health disparities. Um, the study uses the example of Ethiopia, drawing similarities between there and Mexico and Chile, where they used a broad disease intervention to build into the package, and then contrasted that with countries like Malawi and Kenya, who focus more on primary care and link these with community care provisions. In addition, Sub-Saharan Africa and Western Africa also looked more at community care provision and primary care for their essential package. In Ethiopia, the data access to perform the cost effectiveness analysis enabled them to prioritize high, medium, and low categories of service provision, and other countries were noted to differ substantially. Some looked narrowly only at disease burden and cost effectiveness, while others included equity, financial risk protection, budget impact, and social acceptability. In terms of COVID-19, Ethiopia decided early on to maintain essential health services as part of their response, and used their essential benefits package to protect those services throughout the pandemic. So that's another thing to consider when you have a lot of private health insurance might be linked to work, and if in the event of something like extreme weather event or pandemic, populations need protection to know that they can access healthcare when needed, and that their insurance might not be taken away from them. The study highlights the differences between individual countries in terms of priorities for universal healthcare and cost-effective analysis that demonstrated the need for countries to consider extending the inclusion criteria to not just be looking at disease burden and cost effectiveness, but also to include health equity measures and financial risk protection. Sorry, I said that already. Leadership and oversight was required from Federal Ministry of Health. They conclude that a well-designed, evidence-based program will save lives, reduce health disparities, and protect against impoverishment. So they're also reinforcing the need that this oversight in ensuring that when you're creating the program, you're including ways to ensure health equity, and also then to monitor ongoing. The article by Pettigrew et al. Looks at voluntary health expenditure in low and middle income countries, exploring trends between 1995 and 2012 and policy implications for progress towards universal healthcare. The paper highlights some of the challenges faced as countries aim to progress equitably towards universal healthcare. The authors use data from the World Health Organization database as well as literature analysis to look at potential reasons for trends in countries and regions. Interestingly, they found that many countries demonstrated a rise in voluntary health insurance, that would be private health insurance, over the study period, which is within the time when all countries were signing up to more to provide universal health protection, universal health care. So why that's not good news if that is happening, but we'll look at why. Two of the biggest countries, India and China, saw an increase in just a slight increase in voluntary health insurance, and as well as a rise in out-of-pocket payments and a fall in general government health expenditure. So that is concerning, like what's happening with the move towards universal health coverage. If there was more universal health coverage, you should see the general government health expenditure increase. So, and the two regions demonstrating the most growth in voluntary health insurance were Africa and the Americas. In terms of moving towards the global agreed goal of improving health equity, and this does not bode well. The study states there are many reasons for this trend, including external influences and government policies, but they also suggest that many countries have paid insufficient attention to including equity, which is a similar finding to the Vergey et al. Study that also advises that equity needs to be addressed and cautions the risk of fragmentation with voluntary health insurance. So what I thought was interesting here, and what they do discuss also, is another reason sort of why it might not be such a bad thing, but it needs oversight and governance, and care needs to be taken. So what's happening is we have poorer countries trying to implement a healthcare system, financial limitations on how much they can provide. There are going to be gaps. And are we going to bring in the equivalent of what we have here would be Medicare supplemental insurance to help bridge the gaps in Medicare for paying for your medications that are more expensive than what Medicare will cover. So you get your supplemental insurance to cover those costs. And so what I think they're suggesting, we're seeing, especially in West Africa and sub-Saharan South Africa, post-apartheid, and also in South America, is that's what's happening. You're getting private insurance coming in to help cover what's not covered by the universal healthcare. So if it's managed well, it could be a good thing. And I believe it, because we have awareness and population health is taking off, and value-based care is becoming more and more accepted as like the future. I know that I'm working within I think it's the biggest insurance company in America, and it's a global company. They own some of the private companies in South America that are providing insurance, also healthcare provision, hospitals. So this is an area where we need to watch carefully about how it's being regulated and monitored and using population health methods to check for equity, and that so you might have a universal health care that is available for all, and the the people who can't afford or are unable, to buy their own supplementary insurance might be able to qualify for a subsidized supplementary insurance. So that, I mean, there's a lot of, this is just my way of thinking how it could pan out in the future. So, and I do feel very positive. Personally, I would never have thought of myself as working for an insurance company, but as I progress in this course, I'm seeing more and more what we're doing, embracing value-based care, embracing equity, inclusion, and diversity, looking at how we're working seems to be going with everything I'm learning about how we need to have more public-private working together. And if we're using AI and wanting to protect data, we need to have substantial systems in place to enable that to happen safely. So Pettigrew also warns that it, you know, we can use voluntary health insurance in addition, but we need to move forward wisely in order to progress towards still maintaining universal care. And they also highlighted some positive impact that in South Africa post-apartheid, the government actually stepped in to regulate private health insurance, voluntary health insurance, to ensure that equity could be maintained. So we need regulation from government and monitoring. Mobilization of resources, national policy development, ensuring that the people who need resources have access to those resources. So investment in rural areas, developing healthcare provision as well. And learning from the experience of other countries, investing in prevention and primary care, ensuring financial protection from catastrophic health expenditure, and that's embedded in any system, and that out-of-pocket costs should not be too much, if at all. So I think it is achievable, and I feel positive if we can have transparency, invest in IT and technology, keep it affordable, focus on reaching these at-risk groups, improving quality outcomes and access to health. We can control overall expenditure with better preventive care, reducing cost overall, as has been seen in other countries. Improved communication and less fragmentation. I think the future could be promising. Thank you for listening to me today. If you have any questions, let me know, and I look forward to your feedback. Thank you.